Primary liver cancer is the second most common cause of global oncologic mortality, with over 90% attributed to development of hepatocellular carcinoma. Liver transplantation is the gold standard for curative intent and long-term survival in the setting of small, unresectable HCC. Unfortunately, a significant proportion of candidates who initially meet criteria will develop tumor progression and become ineligible or drop out. Hepatectomy is another opportunity for cure that does not require waitlist time and includes candidates ineligible for transplant. Unfortunately, the extent of chronic liver disease does impact or prohibit resection in patients with high risk of post-operative remnant hepatic failure. The need for locoregional therapies emerged as solutions for decreasing risk of tumor progression while on the waitlist, downstaging ineligible transplant candidates, reducing recurrence risk after surgery, rescuing patients with recurrence with prior resection, and treating patients with curative intent with chronic liver disease ineligible for resection due to high risk of postoperative hepatic decompensation. There are a variety of locoregional treatments that have been widely adopted and include transarterial chemoembolization, or TACE, and minimally invasive microwave ablation, or MWA. The effect is facilitated through pathologic tumor necrosis, and achieving a complete pathologic response is a strong predictor of tumor-free survival. In order to help guide treatment, this study serves to investigate the differences in efficacy of locoregional treatment through pathologic assessment, particularly between TACE and MWA, on tumor viability and long-term outcomes, and the accuracy of preoperative imaging in treatment success. A retrospective review of all patients who underwent hepatectomy or transplantation for HCC were reviewed over a 10-year period at a single-center tertiary institution. Inclusion criteria were adult patients with HCC and use of a locoregional treatment, either MWA, TACE, or both, prior to hepatectomy or transplantation. Patients were grouped into one of three cohorts, either MWA, TACE, or both. Chart abstraction and explant pathology were used to record the listed variables for each cohort. 91 patients were identified with HCC who underwent locoregional treatment prior to resection or transplant. Of these, 14 underwent microwave ablation alone, 46 underwent TACE alone, and 31 underwent both alone in a neoadjuvant fashion. The TACE population was significantly older than the other two cohorts. Otherwise, there were no differences in gender, race, or BMI, with the majority being Caucasian and male. The TACE cohort had the largest tumors on explant specimen with more T4 tumors. Otherwise, there were no differences in the number of tumors or the amount of fibrosis or steatosis present between cohorts. The amount of viable tumor found in the explant specimens significantly varied between cohorts. 57% of microwave ablation alone had no viable tumor present on pathology, whereas only 13% of TACE patients and 29% of both MWA and TACE had a complete response. There was 17% viable tumor found after microwave ablation, 49% after TACE, and 19% after both therapies. Time to recurrence was fairly similar between groups. Median overall survival was significantly better in the microwave ablation and TACE cohort, followed by the microwave ablation alone cohort than the TACE cohort alone. Overall survival was 63% in the TACE cohort, which was lower than microwave ablation alone and both therapies. Tumors were stratified by size, and the survival advantage remained significant in tumors greater than 3 centimeters, with improved median survival in the microwave ablation alone and the microwave ablation and TACE cohorts versus TACE monotherapy. Additionally, for tumors less than 3 centimeters, microwave ablation alone was most effective, with over 70% of patients having no viable tumor on pathology versus 7% in the TACE alone and 50% in the both cohort. Microwave ablation alone was also more effective in the larger tumor cohort greater than 5 centimeters, with 100% having no viable tumor on pathology versus 13% in the TACE alone and 43% in the both cohort. The ability of CT imaging to predict tumor viability was assessed by treatment modality using positive and negative predictive value and sensitivity and specificity. For microwave ablation alone, CT scans demonstrated a 75% positive predictive value and a 67% negative predictive value. This correlated with a 50% sensitivity and an 86% specificity. For TACE, CT scans demonstrated an 87% positive predictive value and a 25% negative predictive value, correlating with an 82% sensitivity and a 33% specificity. For both microwave ablation and TACE, CT scans demonstrated an 80% positive predictive value and a 39% negative predictive value, correlating with a 42% sensitivity and a 78% specificity. Local regional therapy has become a key component in the treatment algorithm for HCC due to its successful induction of tumor necrosis. Employing modalities with low morbidity and mortality, local regional therapy stalls tumor progression, decreases platelet dropout, and even can be used in a curative fashion. We report the pathologic differences between local regional therapy approaches, with the distinctly superior effects with microwave ablation alone and microwave ablation with TACE offering an advantage over TACE monotherapy. This study investigated the efficacy through the gold standard of pathologic response. The pathologic specimens treated preoperatively with microwave ablation had significantly less viable tumor than TACE monotherapy, 17% versus 49%. Further, 57% of microwave ablation alone had no viable tumor remaining at all on pathology versus only 13% in TACE monotherapy and 29% in both therapies. This effect was present with or without addition of TACE to an ablation, with no significant difference between viable tumor amounts after microwave ablation alone versus microwave ablation with TACE. These pathology results suggest that microwave ablation is a more destructive and effective modality for HCC, and this is implicated in survival and recurrence. Patients live nearly twice as long in the microwave ablation TACE cohort with a survival of 140 months versus 75 months after TACE alone. Interestingly, although there was no difference in tumor response with addition of TACE to microwave ablation, there was a substantial improvement in survival of nearly 4 years. When stratified by size, the survival advantage persisted in tumors greater than 3 centimeters, which further promotes the belief that microwave ablation is more effective than TACE, and this effect is not due to tumor burden or selection bias. Local regional therapies have proven to be highly effective and instrumental in improving morbidity and mortality in patients with HCC. While both therapies induce tumor necrosis, the impact of microwave ablation appears to be markedly superior to TACE by pathologic evaluation of explant specimens. With higher rates of complete tumor necrosis, the extent of the effect of microwave ablation may be associated with improved survival. We are currently working to confirm our findings in a prospective randomized trial. Thank you very much.